Richard says, my name is Anne-Marie Ross. I'm a reporting radiographer and the lead radiographer for A&E. I work at Monklands Hospital, but today I've been asked to come along and speak to you about my secondment day. I work 1 day a week at the Scottish Clinical Imaging Network, where I'm the network imaging manager. So University Hospital Monklands is where I work, and pre-COVID I would have had to travel to Glasgow and Edinburgh to the offices there, but my whole secondment so far has all been on Teams, so I'm all over the country from my own kitchen in the 1 day. Today my plan is to talk a little bit about how skin began, a little bit about the structure, but mainly I want to tell you what I do as a network imaging manager. How did skin begin? Quite noisy. Recommendations came from Audit Scotland and Scottish Diagnostic Steering Group, tasking Scottish Government and health boards to work together. So in 2014, the National Managed Diagnostic Network was set up, and from that along came skin. The remit of the network was to work with health boards acting as a conduit between radiology services and central projects coming from Scottish Government. The vision is quoted here, and to support this you'll find the aims and the terms of reference on our skin webpage. So what we look for is a wide range of continuous work to challenge health boards, to ensure we're always improving standards and to ensure that there is a quality of service to patients from all across Scotland. Skin does this by gathering and sharing data and presenting this back to the health boards and imaging executive board. This is quite a complex slide, but this is the governance for our national managed diagnostic networks. I was quite confused by it when I first started. Where we are is at the bottom right-hand side, the national managed diagnostic networks, and we work our way, I nearly said superiorly there, but you'll get that. We go to the Imaging Executive Board, and then we feed into the Diagnostic Steering Group, which then goes on to Scottish Government. And you'll see that the chief executives and the health boards all feed into this, so a lot of information flows forwards and backwards all the time. Sorry. The core team. This consists of myself as a network imaging manager. We have a consultant radiologist as clinical lead who's just coming into post in the next 3 weeks. We have the programme manager and a programme support officer. So we meet at least once a month, usually the first Thursday of every month, and we get together to review our developing and delivery of our work plan. We look at anything that is outstanding and any new or any suggestions for new projects. We make a report of all of our work in our mid-year and annual work plans, and deadlines and targets are always in place to keep the momentum going and keep the work moving forward. The steering group, we chair the steering group, and it meets at least 3 times per year, and that encourages communication across all of our groups and to prepare for one educational event every year. I'll talk a little bit about the work plan. It's quite essential to all of our work. It's a great guide. It contains all of our projects, and we manage it using a RAG status, a red, amber, green status. So this is always transparent for anyone to have a look at. It's developed by the programme manager and the core team, and we get input actually from all angles. We get suggestions and ideas from Scottish governments, from health boards, from the steering group meetings, and also sometimes from cancer charities as well, some audits. The existing and proposed work plans and reports are issued to all of the groups mentioned here so that they can input and consider for themselves. The steering group membership, this is the steering group. We meet 3 times per year, and I feel myself this is where it all comes together, where we all get to meet and exchange all of our ideas. As you see, it's quite a wide range of people. It's always good to have the IRMA inspector at our meetings so that we know what his plans are for the next 2 or 3 months and we can prepare. What's also I find quite useful is recently we have asked the chair of all of the special interest groups in Scotland to come along and give us an update. They don't report into us, they have their own networks. We have assistant practitioners, breast, CT, MRI, paediatric, reporting radiographers, ultrasound and imaging nurses. So the chair of all of these groups can come to us and give us an update and also take away any information that might be pertinent to their group. So what do I do? I had to double check this with my programme manager, so you better remind me, what do I do? It is a fantastic job. It's really good for me. My other days clinical, and when you're working in a difficult, as we've all talked about, a difficult atmosphere where we're short-staffed and units breaking down and demands on our service, it's really good to know then that there's work going on in the background, and it's very good to go to, sometimes we have the opportunity to chat directly to Scottish Government and say, this is what's happening on the ground as well. So we go over our work plans, and this is just some projects we've been working on in the last few months. I was invited to join the steering group with RCR and COR, and that was very good to be part of the quality review service for the quality standards for imaging. And hopefully we'll look towards adopting that in Scotland, but that might be a little hurdle. I met with the Prostate Cancer UK Director, and he was wanting to talk about the MRI prostate delivery following his launch of the Prostate Cancer Awareness Campaign. I've met with a physics group recently who are suggesting issues at one particular health board, and they want to know if that's the same across Scotland. What they want to look at is the standardisation of safety questions for MRI, that they can be the same questions across this country. Some of you might have experienced that what comes across in the request is not what the patient tells us about on arrival, and that creates some delays there. I was invited to speak to the National Optimal Lung Cancer Pathway to give a radiology input to the MDT team, what radiology would be capable of and what would be acceptable. I continue to support NES, that's the National Education for Scotland, as they continue to support me, and I've developed strong links with SRTP, that's the Scottish Radiology Transformation Programme. Just to conclude shortly, one of the strands of work that I'm enjoying working on for quite some time actually is to support our assistant practitioner work, and then it's good to hear that we've overlapped a few times today, and we're all agreeing that this is quite an essential group of staff. So what I've been working on is we've developed a scope of practice document that requires completion and sign off with approval of governance for change of practice and input from IRMA. We've also developed some at one of the managers groups that said, but how do we do that? What is the safest way to do that? So we've developed a flow chart, and both of these documents are going to the Imaging Executive Board Clinical Reference Group in the next coming weeks for governance approval, and then we can launch them. We will process results of 2 analyses we've put out recently, a service needs analysis to all the managers and a learning needs analysis to the assistant practitioners. And we had also done that pre-COVID, so we'll compare, are the needs the same before and after, and hopefully that will help us develop workforce planning and training modules that may require in the future. We have developed a DEXA workplace module, and we hope to pilot that possibly in Glasgow shortly. Within Lanarkshire, we have a pilot that's just about finished, and this is for the AP to check their own images, but where it would be plain film image appraisal when the patient is going back to a clinic, so that there is that safety net there. So that would be like orthopaedic or the chest clinics. We're also discussing with NES, where there was a small expression of interest into routes into radiography. So we'll have a look at that. That will affect radiographers and assistant practitioners. And we're hoping to create a generic job description. And for the future, we want to work with our HEI colleagues to see if some of these work-based modules can acquire any educational award that they could then use possibly towards going to a radiography course or use towards apprenticeships at some point. And we hope to look at national uniform. It's a bit up in the air across Scotland. and develop a generic framework. Scottish Government are actually looking at band 2 to 4 generic frameworks for AHPs, and we hope to bolt on a profession-specific one for radiology. And just quickly to finish off, as you can see from my personal reflection, it's a hugely rewarding role. I thoroughly enjoy it. Sometimes it's more than a day's work, it often spills over, but mainly because I can see the benefits for radiology staff and linking everyone together across Scotland. It's great to see people coming together and people taking answers back to the departments. So I would encourage networking, however small or large you might be able to develop, ask for help, speak to each other. But mainly, as we've said already today, it's putting the patient first, and the patient has got to be at the centre, as we've all said, of everything that we do. So, some reflections, and just to thank you very much.
Thanks, Anne-Marie. We'll take any questions on this session at the end of this. So next up, it's Cora Regan from Northern Ireland. Cora's got another central role, leadership role for a radiographer, working to the Chief Allied Health Professions Officer. So let's hear from you, Cora.
Thank you very much. Thank you, Phillips, and thank you to the Society of Radiographers for inviting me to speak today. My name's Cora Regan. I am currently the Professional Imaging Lead for Diagnostic Radiography, and I'm working currently on secondment out with the Department of Health in Northern Ireland. So what we're going to do today is I'm going to run through several steps just to give a bit of an update and a current position, if you like, on what radiography is doing in Northern Ireland. Start out with a bit of background, talk a bit about advanced practice. I'm going to cover the challenges and the opportunities that we have in Northern Ireland, and also the next steps and what we envisage for the future as well. But central, and it's been said several times today, we keep our patients at the core and at the heart of every single thing that we do. So a bit about my background. I'm a diagnostic radiographer. I trained in fluoroscopy. I've also got a background in practice education. And I also have worked extensively with the Society of Radiographers, both in terms of industrial relations as IR rep, and also on both the Northern Ireland Council and the National Council as well. My substantive post, when I'm not seconded out, is Assistant Clinical Services Manager for the Northern Health and Social Care Trust, and I also acted in the Interim Clinical Services Manager's post through the pandemic as well. So I'm often asked, what does an imaging lead do? And it's a very good question. My brief, when I started on the 1st of October 2021, and my brief was that I design a proposal for radiography advanced practice in Northern Ireland, that I quantify the amount and type of advanced practice that's being done currently, and I propose how the current advanced practitioners who are already trained can be freed up from frontline services to be able to practice. And I was given 6 months to do that. So, no small challenge. In reality, what the job entails is networking quite a bit with colleagues within the civil service, which was a real eye-opener for me, promoting the profession amongst government, which you'd be really surprised, and it really surprised me, how the policymakers really don't know a lot about what radiographers do. So it's about creating and raising awareness of that amongst those who are writing policies that impact massively on imaging services. Working alongside the regional managers in Northern Ireland and the Department of Health and the SOR to drive forward the radiography agenda and to make sure that the radiography agenda is part of the overall larger, bigger picture agenda. And assessing the workforce to ensure stability, recovery, and plan for increases in advanced practice. So I'm going to give you a bit of a summary about Northern Ireland healthcare at the minute. So we have a population of 1.9 million, roughly the same as Greater Manchester, yet we have 5 healthcare trusts with 5 radiology services managers and very different teams who often historically worked very much in the silo mentality. Reforming the overall system in Northern Ireland is stagnated, And anyone who's watched the news of late will know we have no political leadership or accountability as well. So we are in a difficult position. We also have the accolade of having one of the worst waiting list positions in Europe currently, which is not an accolade that we want to continue. So as you can see there, as I said, our population is 1.9 million. You can do the maths there. We have patients waiting up to 5 years for outpatient appointments. So this is a position that is untenable and cannot continue. So how did we get to this position? Well, it's not unique to Northern Ireland. We haven't enough radiographers. We haven't enough consultant radiologists. We have a lack of recurrent revenue funding. Often the funding in Northern Ireland is gap, non-recurrent funding, so you're not able to recruit into posts. Lack of ring-fenced capital funding for equipment, years of reduced funding, and a lack of workforce planning. But this is not unique and not short-term. This is not a COVID problem. This is a 25-year problem in the making. So you can see there the graph, and that's exponentially how waiting lists have grown. And added to the top of that is the names of our health ministers during those times. 21, 22, we don't currently officially have one, so there isn't one added there. So why do we need radiography advanced practice? Huge waiting times. Our emergency department plain film reporting waits greater than 2 weeks in a lot of cases. A large amount of reporting is outsourced to the independent sector, obviously at a huge cost to the public purse. And due to rapidly increasing demand, that safety net that we had in the independent sector is no longer a given. We no longer can be assured that the IS can step in to help out when we really start to increase our backlogs. So what current radiography advanced practice do we have in Northern Ireland? Well, we have a number similar to what is right across the nation. Reporting radiographers, we have one consultant diagnostic radiographer in Northern Ireland, and that's in breast imaging. We have specialists in fluoroscopy, ultrasonography, but we have sprinklings in some of the trusts, and it's not consistent throughout the board. And also we have not consistent levels of support from our consultant colleagues as well, which exacerbates that problem. So challenges, as I've already said, our demand is increasing, our capacity demand gap is getting bigger, we have our non-recurrent funding, we have inequality therefore in terms of waiting lists and access to services, and we have a huge requirement to look at the capital investment in Northern Ireland and how that is commissioned and delivered to services. We have too heavy a reliance on independent sector providers. We do know, and we all acknowledge, that there isn't, we need to be in partnership with the IS, but we're relying currently too heavily on them. We need to build in a longer-term plan. I've dwelled a lot on the negatives there, but there are some opportunities as well. In my role, there's a huge engagement with the workforce. I'm regularly meeting with the regional managers, with trusts, with our Health and Social Care Board as it was. They've now joined the Department of Health. And there's lots of strategies that have been published in Northern Ireland for which radiography aligns really closely. The elective care framework, the cancer strategy, the workforce strategy. And there's the opportunity to invest in and support the workforce on the back of those. We have regional networks such as the Modernising Radiology Clinical Network, or MRCN, and we have the Regional Medical Imaging Board as well. We're looking at planning and future-proofing those services, and one of my jobs, along with colleagues, was to write a submission to the then Health Minister, looking at the entire workforce, not just at advanced practice, but right from support workers up, and letting them know that what we need, and a very basic start, is an increase in the training numbers for undergrads and consultant trainees. We're in a very lucky position that the region has been driving towards QSI accreditation, and 4 out of the 5 trusts have either been recommended or succeeded in achieving their accreditation status. We also are quite lucky when listening to other colleagues in that we have a programme for a complete regional PACS system, the NIPACS Plus project, which will come online in the next couple of years, and that will make all 5 trusts interconnected and will be integral as well to the plan for an imaging academy in Northern Ireland as well. So next steps are Development of the role of the assistant practitioner. We're really not utilising them enough in Northern Ireland. It's something we really need to do. Exploration of apprenticeships. So I've been meeting up with Kerry, and we're looking to try and get all our ducks in a row, that when we do get this magic funding, if it ever comes, that we will be ready. Implementation of the recommendations of the Strategic Review of Imaging Services and the Diagnostic Workforce Review, which has just been published this month. And it was actually written in 2018-19, so it's already out of date. So we need that already implemented before we can review and go forward. But we do have regional collaboration. We are looking in the future to go towards a radiographer reporting hub. We already have had some trusts helping out where there are backlogs in others, where they maybe have a greater number of reporting radiographers. So that willingness and that acceptability is there, and that collaboration is key. We need commissioned courses available in Northern Ireland so that our staff don't have to travel, increase cost, etc. And we do have a plan to take forward through Ulster University the first reporting radiographer programme, which will be starting in September 22. So extension then of the radiographer reporting is a big thing as well. We want to be getting the support for our radiographers to train in CT and MRI. It's being done elsewhere. We just need the support to be able to do that. So hopefully I haven't been all negative. There are a lot of opportunities out there, and there is light at the end of the tunnel, which hopefully is not an oncoming train. We have to live in hope. There's lots of challenges, but plenty of regional projects going on. We've scope for further collaboration, as collaboration, communication, and working together is key to this. And I'll leave you just with a quote from Henry Ford. Coming together is a beginning, keeping together is progress, and working together is success. Thank you.
Thank you very much, Cora. And finally in this session we have Chris Kalinka, who is from Wales. Naturally, that's how it works. He's also the chair of UK Council of the Society of Radiographers. So let's hear from you, Chris, on your work in Wales.
Thank you, Richard. I'm Chris Kalinka. I've been a radiographer for 37 years. I've been a radiology manager for 20 years. I've been in all of your positions. I know how tough it is. But I was president during the COVID year, and that was quite tough because I didn't see a lot of people. But it also was equally tough, and you think you've got a management challenge. I had to manage Richard for a year. So, you know, I think that's my claim to fame, and survived that, so that's good. I'm going to talk a bit about our imaging program, and I'm going to talk a little bit about leadership afterwards as well. So, we've got a national imaging program in Wales, funnily enough, and it does include all our health boards, and we have a couple of trusts as well, so everyone's included. We're reshaping our program. We've got a new vision to support our statement of intent and including COVID recovery. And I think the bit in italics is a bit of work in progress really around the strategy that we're working towards. And where we'd like to get to is 2 weeks for everything. That's a fairly straightforward aim, I think. And if we can get 2 weeks to report, then we'll be in a good place. I don't think many of us are in that position now. The lists have certainly got worse, but we need to get better, and we need to have something to work towards that national government recognises. So they, in common with some of our other speakers, national government know more about imaging now than they used to, but that's starting from a low base. So profile, leadership, education of them, and getting diagnostics up the agenda really important. So we're going to have a new National Diagnostic Board. Now that'll include us, there'll be endoscopy, there'll pathology, and a few other ologies as well. But that will give us another route into Welsh Government. So let me show you where we are at the minute. A busy slide. That's our governance structure that the programme is running under at the moment. So at the bottom, more or less, we've got work streams. I'm involved heavily with the imaging workforce and education, but actually during COVID, we also set up the Imaging Essential Services Group, and that's where the work's done. So that includes all our health boards, includes all our clinical directors, includes our radiology service managers, and some link people from the trust as well. We're trying to keep the work in that group and control it, where we report then to the Imaging Programme Strategy Board. That will probably amend and feed into our new diagnostic board, but that isn't there yet. We're holding control in imaging essential services because we will then have control of what happens there. It'll be a very operational group. That's where the work done. And we'll feed up to the imaging program strategy board, but we're looking for that to be an overseeing quality board rather than an operational board. So we're trying to change the membership a little bit and, as I say, keep control in the imaging essential services group. I think you can see in there we've got a lot of the common themes as well across the work streams. Informatics, semi-detached from us, but we're again looking at a national procurement in Wales for an imaging system. And I think the key word is system. We're trying to get away from RIS and PACS and all that stuff. One of my hobby horses is really integration of systems, because God knows we run around a lot with bits of paper trying to track patients at the moment. Do we need to get away from that? So integration, really important. Echoing what we said earlier on, I think some of the networking really important as well. And I'm a bit jealous of Northern Ireland because we don't have an imaging lead. We have leads for cancer and we have leads for for cardiacs who are well known in Wales and strong mouthpieces. We need an imaging lead in Wales, I think. That's a personal view. I really think we do. I don't mind who does it, but it needs to be a recognised person who government will get to know. Talking about government get to know, we looked at Imaging Essential Services Group, and that's a COVID sort of name. We were going to change that, and we decided not to. Because we'd produced documents during COVID, the Essential Services Group is known to Welsh Government. So we're going to keep the name, even though it's not ideal. I work on the Imaging Workforce and Education Group. We're developing a comprehensive imaging workforce strategy. A lot harder than it sounds. We've agreed scope last year of radiology engagement, and I'll go through some of that in a second. We've surveyed some of the training that we were doing, and we actually did some workforce training with our radiology managers as well. I didn't get much workforce training when I was growing up, and I'm sure a lot of you have neither. So we tried to get some consistent training across Wales. And actually during that, we learned quite a lot about access to training funds, which the managers didn't know about. So getting an organisation called HEIW, which is Health Education Improvement Wales, together with the managers has actually been really useful. Get the same people in the same room, they've done a bit of networking, they've learned opportunities they didn't have before, and they got something from it. It's important that we give people some return for their time, so they did get something from it. What we've done was this, which is another busy slide. Essentially, we ran a load of workshops with our radiology managers and with our consultant colleagues. And that ran probably from around July to December, and then follow-ups in January and March this year. So we went through it, we covered everything that's on there, and apologies if that is a little bit fuzzy, but we covered all of that in our workshops. We also got people in to give examples of good practice, and we really had a very good talking shop and feedback with all the radiology managers. And having that opportunity to have a national workforce plan in Wales, we've never had that. So it's a real opportunity for us to get into Welsh Government and get that plan there. And I'm hearing similar things in England. I think we may well be, I'm not sure where you are, I think we're on different tracks, but actually promoting that opportunity is really important to get into the ear of government. That's what we found. We found things are quite bad out there. We found people had lots of comments in the middle, so we can condense that into an infographic. We did a bit of work with a media company, and we wanted something on a page that people could read, pick up lots of stuff from, and absorb easily. And I love an infographic. I think they're really good. So we started at the bottom. We worked our way through. We heard lots of people, so lots of speech bubbles there. We then came out with, the service is quite tough at the moment. Things are not great, and you've all reflected that today. And then we started to talk about, well, if we're going to make progress, how do we do that? The way we're going to do it is the areas at the top. So we'll have our 3 focus areas, and we'll have action plans coming next from this to actually address those areas. And there's a bit of everything, to be honest. There's a bit of advanced practice, there's a bit of future planning, there's a bit about supporting the staff we've got. And we haven't talked a lot about that today. And I think that's really important, is that we do support staff, partly through some of the well-being stuff that we share with our HR colleagues, and partly by giving them the opportunity to actually perform. People struggle at the moment. We've already heard it today around IT integration, around not being able to see things, make people's jobs better, and that came across very strongly in some of that. I'm conscious that way, nearly at tea time, so I'll crack on. Next steps. I mean, I'm presuming we'll publish the slides, so you can all have a look at that again. We're finalising the engagement report, which is working on our findings, working through the infographics, having something that's easily presentable for different levels of government as well. So we can use, we've worked on a slide deck, which has got a lot of the findings in there, which is far more detailed than I'm going to do today, but we'll be able to pull out pieces of that depending on our audience. And I think that's really important. If you produce a very large document, yeah, I think you're going to struggle. You need something that's really snappy at the beginning, grabs people, and gets some engagement and recommendations. So we're going to have an action plan in the 3 focus areas I've shown you earlier on, and then we're going to prioritize that action plan, because there will be a lot of actions. And it's not just going to be us. We'll work with the IWEG group, but some of that work is going to be farmed out, because it's a bit like QSI. It's a job for everybody. It's not just a job for the working group. And I think next bit I'll talk about, very briefly, I'll try and speed up, enhanced profile and leadership of imaging. I've kind of covered that earlier on. Absolutely crucial. We need imaging leaders in political forums talking about the value of diagnostics, the value proposition. It's really important. We did a bit about, we've got leadership as part of our imaging workforce and education group. It's one of the work areas that we look at. We've done a bit of a data exercise. We've looked at gender profiles, and spookily enough, we're a female-orientated profession. But I think in common with lots of other things, that doesn't translate into radiography leadership either. We'd probably have a disproportionate amount of, let's call it, traditional white males in leadership. And I think it's important that we actually look at equality to get for our leaders as well. It's not something that we've spoken about today, but it is important that our leaders reflect our workforce. We did some sharing of advanced practice and consultant posts, and we've had lots of that quoted today already, so I'm not going to go into that. Just to add something to the discussion earlier on, I think what is also really important is support for those people in consultant posts. Consultants are very well supported. They get SPA, they get appraisal. Now, to me, I think for a radiography consultant, that needs to be a 2-stage process, because I can appraise somebody, but I can't appraise their clinical practice. So they get appraised with the manager, and they get appraised with preferably a medical person, doctor, or a peer. And let's look at our peers and support each other as well. We found lots of leadership, actually, in the workshops. Very, very positive. People had a lot to say, and they turned up while the pandemic was on, which was fantastic. And leadership development. I'll talk a little bit about that in a second, but it's really important that we identify our leaders and we develop them. So, we've got leadership in radiography. We need to identify talent and succession plans, and we do have an aspiring director programs. We've got multi-professional programs, mentioned HEIW earlier on, and we do have some advanced clinical leadership programs, and it's informing people and getting access to those is really important. We've got radiography-specific courses, and we've covered some of those earlier on, and the forthcoming career framework documents coming from society as well will help with that, and will help at different levels and different bits to do at different levels. We have a Gwella or a Gwethla portal, which I'll show you in a second. So it's an online resource that people can get into. That's what it looks like. I think that's accessible to anybody in Britain, so I think you can get across to have a look at it. You might have to register to actually enroll online, but there's stuff in there that's really useful for all sorts of leaders, because people come with bits of skill. They don't come as a finished package. We all develop as we go along. That's me done. You'll be relieved. And just to reinforce what I said earlier on, there's a chunk in there around compassionate leadership. I think compassionate leadership is really important. I think our people have had a tough time. They need to be looked after. And personally, I know that if you care about your staff and you support them, they'll follow you. If you don't, and you treat them badly, you'll have a much more difficult time. So compassionate leadership looks after them, and it makes your life easier. So that's me done. Thank you very much.